Thank you so much, dear colleagues. In this speech, I will try to summarize the results of radiosurgery for rare benign skull-base lesions. So, yes, in that speech, I want to collect only the tumors of cavernous hemangioma of the sinus, paragangliomas, and non-vestibular schwannomas. Let's begin with the cavernous sinus hemangiomas. They are very rare tumors, but they are very vascular tumors. And to operate a patient with cavernous sinus hemangioma may become a big trouble for the surgeon. And they mostly shows them with the local mass effect, some kind of cranial nerve palsies, etc. So to do a surgery for these tumors can be very dangerous in the experience sense, like as the Atul Goyal, he's from India and operates thousands of patients, and he also operated these patients. And in this article, you see that there are 3 patients died because of the surgery, and there are a lot of complications related to surgery of the manipulation of the area of that cavernous sinus. So in other article, you see here the surgical results. It is also not mostly probably to remove all the tumor out. You will leave the room with some residual tumor, hemangioma, and also the complication rate is not acceptable for 21st century. So we have to think about radiosurgery for these patients. This is my first article in my professional life about radiosurgery, and it is about cavernous sinus hemangioma. So when I see a patient with cavernous sinus hemangioma, I love that patient and I love that tumor. So in the articles in the literature, you will see that the success rate of radiosurgery in these lesions are very, very high. In our center, we have treated more than 40 patients, and I never see any recurrent hemangioma after radiosurgery. And the complication rate is very low. So why do we stay with surgery for these patients? This is a large patient group. The results here, you will see that the success rate is 100%, and the complication rate is very, very low when you compare it with the surgery. And also, if the lesion is large, you can use hypofractionated treatment. And here in that article, you see that the results of hypofractionated treatment is perfect. So they respond well to radiation. And even classical fractionated radiotherapy can be used in these tumors, in these lesions. And here you see they used 50 gray in 25 fractions, and the results are perfect. So if you can understand that this lesion is an hemangioma of the cavernous sinus, don't send the patient to surgery, do radiation treatment, radiosurgery, hypofractionation, or even classical radiotherapy. So there are a few examples. This is a patient with a small cavernous sinus hemangioma, and after 6 months, the lesion is smaller than before. This is a large lesion with headache in this male, and because of the size was large and close to optic nerve, we decided to do the treatment with hypofractionation, 5 times 5 gray, and this is the result. The tumor almost totally gone after 1 year. So because of the radiation therapies are very good option for these patients, we have to diagnose the patient depending on the imaging. We should not have a biopsy or not surgery, etc. So if you check the literature about it, you can easily define that this lesion is hemangioma. So for the lesions, when you are not very convenient about the classical MR or CT, you can use labeled red cell blood pool scintigraphy for those patients, and it will show you that this is an hemangioma. For cavernous sinus hemangioma, as a conclusion, I would say that radiosurgery is very successful, any kind of radiation treatment. And for the large ones, you can use hypofractionation and even fractionated radiotherapy. For glomus jugulare tumors, glomus jugulare and glomus tympanicum tumors are scientifically paragangliomas. And the paragangliomas are paraganglia tumors. So what is paraganglia? Paraganglia is a group of non-neuronal cells derived of the neural crest. They come from ectoderm, and they are very close proximity to the sympathetic ganglia, and they may have chromaffin or non-chromaffin cells. Glomus jugulare tumors and glomus tympanicum tumors are mostly non-chromaffin cells, so they don't produce epinephrine, norepinephrine, etc. So what we mostly deal with in radiosurgery, in our daily practice, we mostly deal with glomus tympanicum tumor, tympanic paraganglioma, or jugular paraganglioma, which is glomus jugulare tumor. A lot of years ago, we published our results with glomus jugulare tumor, and the results were very nice. And here you will see some systematical reviews on this subject, and here you see that the tumor growth control rate in many articles is 100%. So what can we say to the patient? That most probably more than 90% of chance your tumor will not grow anymore. So the complication rate is also low. When you operate a patient with glomus jugulare tumor, you may have a lot of complications related to the localization of the tumor. So another article which made a systematic review, and you see here the tumor control rate is very high, and the symptom control, I mean the relief of the symptoms of the patient is also high with this treatment method. So this is a patient with glomus jugulare tumor, and when you are treating a glomus jugulare tumor, we have to be very careful about the tumor's neighborhood to the facial nerve, because if you irradiate the facial nerve with high radiation when you are using to affect the glomus jugulare, okay, you may make damage to the facial nerve, so you have to be very careful about it. And this patient had received 13 gray for this. And also, very seldomly we see glomus tympanicum tumor, and these are mostly small tumors, at least in our series. Angiography shows a blushing in that area, and you can treat this tumor with the same doses. In most of the literature, between 12 gray and 16 gray is used. In our center, we mostly use 13, 14 gray. So for paragangliomas, these tumors, surgery for tumors can be so bloody and very dangerous. So if the tumor is good enough volume for radiation, we have to choose radiation instead of surgery, and they respond very well to radiation. When we come to non-vestibular schwannomas, they are a bunch of tumors, different, developing from different cranial nerves, and almost 10% of the schwannomas in the head are non-vestibular schwannomas. And mostly we do see trigeminal schwannoma in this group. Trigeminal schwannoma is a tumor of trigeminal nerve, and the patient may have facial numbness, diplopia, headache, etc. But when you do a surgery for these tumors, for trigeminal schwannoma, you may see a facial hypoesthesia, and it can be persistent in a lot of patients. And you may have some other cranial nerve deficits. And also related to the every craniotomy, you may see CSF fistula, hematoma, infection, venous infarction, etc. And depending on the series in the literature, you may see half of the patients are having a total excision, sometimes all of the patients having total excision. But when you do, this is an article from our center also, we published it a lot of years ago, and when you treat these patients with radiosurgery, they respond very well to radiosurgery. So this is a guideline or expert opinion from EANS, and they said that Stereotactic radiosurgery offers good control rates for smaller tumors and can be offered as primary treatment. And risk advanced fractionation may allow SRS for larger tumors. And this paper coming from skull-based neurosurgery group of EANS. So the person who wants to operate, they advise radiosurgery. So other articles also show that same thing, high success rate, low complication rate. High success rate, low complication rate. Here also you see tumor growth control rate is more than 90%, decrease of the volume of the tumor is more than 60%, progression seen on the 9% of the patients, and the improvement in these cranial nerves can be seen after radiosurgery for this group of the patients. For jugular foramen schwannomas, they are also very tricky tumors for surgery, for craniotomy, because of the placement of the tumor. There are so much important vascular structures there, important cranial nerves there. So you may see a patient with jugular foramen schwannoma because of hearing loss, hoarseness of voice, facial paresis, diplopia, ataxia. These kind of complaints can be seen. But when you do a surgery for those patients, lower cranial nerve dysfunction rate is almost 50%. It's very, very important. It is more important than the facial palsy because you cannot swallow your water. It's very important. And you may see other cranial nerve palsies also, other classical complications of surgery. And the total excision rate is between 30% to 100%. If you are a surgeon, you may want to remove all the tumor out, but your complication rate will be very high. If you do a conservative surgery, your complication rate will be very low. So for those patients also we published our results some years ago, and in the literature you will see that the long-term follow-up shows us that more than 80%, 90% of the patients get well results after radiosurgery, and the functional outcome is very good with radiosurgery. But if you do a surgery for these patients, you will see a lot of morbidities, a collection of the cranial nerve and brainstem complications. And this is a large article from a multicenter study of IRRF, and it also shows the same. And this is a patient from our series. You see the tumor is necrotic after 1.5 years. Facial schwannomas are also very important, and facial nerve palsy is very important for the life of the patient, of course. And almost half of the patients come to us with facial weakness, some level of facial weakness. Sometimes they come with total facial palsy, and they may have hearing loss, vertigo, etc. And some of them may have hemifacial spasm. And the surgical complications, same as before. Facial nerve dysfunction after surgery, 60 to 70%. Cranial nerve deficit, 8 nerve, very high. Other surgical complications, and the total excision rate is between 80 to 90%. It's easy to remove the tumor for a skull-based surgeon, but the complication rate is high. This is our series about the facial nerve schwannomas. We saw a very good tumor growth control rate with low complications. You see here, mostly the mean marginal dose in the literature is around 12-13 gray for facial schwannomas. And you see here the facial palsy rate after radiosurgery is very low, and the hearing preservation is very high with radiosurgery. So radiosurgery should be chosen for facial nerve schwannomas. This is a patient with facial nerve schwannoma here with facial palsy. She came to us and we gave 12 gray, and this is the 36 month of follow-up of this patient. And this is a male patient, 54 years old, and came with facial schwannoma here. And we did, because of the tumor is growing, we did a radiosurgery for this tumor with 11 gray here, 40% isodose line. Then the first follow-up, nice. Second follow-up, nice. but the third follow-up, it shows that there is a recurrent tumor there. So we decided to give a second gamma knife radiosurgery with 5 times 5 gray for this lesion, and this is the 9-month follow-up of this tumor after hypofractionated treatment. Of course, we have to follow the patient for many years. Other non-vestibular schwannomas, oculomotor, trochlear, abducens schwannomas, they are rare tumors. You cannot see a huge series, 100 patients, etc. But the surgery here also with very bad results. For example, you see here, this is a review article, and they checked for the trochlear nerve schwannoma, and they said that fourth nerve palsy occurred 81% of the cases. So it means that if you operate a patient with trochlear schwannoma, you have to expect that the patient will lose his or her fourth nerve. And the other articles also show that the radiosurgery for these tumors, third, fourth, sixth, etc., the results are very good. Okay, you see here, the results are very good when you compare with surgery. And here also, all three, the tumor control rate is almost 100% in these patients. And the same results with the same, another article. This is a lady with third nerve palsy for 6 months, and there was a schwannoma here, third nerve schwannoma here. And after treatment, you see 6 months later, the ptosis and the visual, the orbital movement is corrected after 6 months. Hypoglossal schwannoma is also a very rare tumor. If you see an hypoglossal schwannoma in your life, once in your life, you are lucky. And the results are almost same. I don't want to say same thing again. The success rate is high with radiosurgery, and the complication is low. So for the non-vestibular schwannomas, I can say that for small or medium-sized tumor, radiosurgery is a good option, and radiosurgical series are much more better than the results of the surgical series. So we advocate radiosurgery for these tumors too. And as a conclusion, whole talk, radiosurgery is a very good option for many benign skull-based lesions. So we have to advocate it in the skull-based neurosurgery meetings also. Thank you so much.
Thank you, very exhaustive presentation. One question for adenomas and one question for rare tumors from the audience.
Well, that was a great talk, and maybe I'll ask a question, and we can also ask the audience also. So do you have any reservation, or how do you deal with when you're dealing with bilateral cavernous sinus tumors and treating with radiosurgery? Do you adjust your dose, or do you consider hypofractionation or fully fractionation in those rare scenarios?
Bilateral.
When bilateral cavernous sinus are involved.
Trigeminal schwannoma, for example.
Let's say, for example.
Well, I will do standard dose for one side and standard dose for the other side 6 months later.
Okay.
Not in the same session.
Anyone else? So would you go to just hypofractionate them both at the same time, or do 54 and 30? 54 and 30? Hypofrac? All right, staged.
Any question for Samuel Chow, pituitary adenomas? No, so we can close the section. Thank you so much. In conclusion, radiosurgery is safe, effective for all the benign lesions in skull base. Thank you.